Bismillahirrahmanirrahim. Today, I will be presenting the topic of diphtheria. I am Dr. Taimia Ayub under the kind supervision of Professor Dr. Saira Afzal, who is Dean Institute of Public Health, Lahore. So, the quote of the day is keep your face always towards the sunshine, and shadows will fall behind you. So, this is the content outline of today's lecture. We will start with understanding the epidemiology and transmission, describing clinical features and complication, and then we will review the diagnosis and management, followed by highlighting prevention strategies, including vaccination, and discussing global and national burden, then recent advances, and then at the end, we will be doing MCQs. This is the learning outcome of today's lecture. So, what is diphtheria? Diphtheria is an acute, toxin mediated infectious disease caused by Corynebacterium diphtheria, gram positive bacillus. The organism produces a potent exotoxin that causes local inflammation and characteristic thickish grayish pseudomembrane in the throat and systemic complication affecting the heart, nerves, and kidneys. Incubation period is from 2 to 5 days. Range is from 1 to 10 days. Communicability up to 2 to 3 weeks if untreated and reduced to less than 48 hours after antibiotics. Epidemiology. The primary determinant is the Corynebacterium diphtheria, which is the toxin producing strain. Secondary, low vaccination coverage, overcrowding, poor hygiene and sanitation, cold season, winter and fall, traveling to endemic areas. So, what is the frequency? Before vaccination, diphtheria was a major cause of childhood mortality. Persisting outbreaks were reported in India, Pakistan, Indonesia, Nigeria, Yemen. Case fatality rate ranges from 5 to 10%, higher in children less than 5 years and in adults greater than 40 years of age. Sources of infection: symptomatic patients with respiratory diphtheria, carriers, asymptomatic or chronic, skin lesions in cutaneous diphtheria, and sometimes rarely from contaminated objects also. Period of communicability: if the patient is untreated, it is from 2 to 6 weeks, and if the patient is treated, infectivity ends within 48 hours after effective antibiotics. Chronic carriers may shed for months. Secondary attack rate is higher among household contacts, particularly in unvaccinated children. Mode of transmission is from respiratory droplet, close physical contact, contaminated fomites. Cutaneous diphtheria spreads through direct contacts with infected wounds, and so on. This the similarly it is shown in the diagram on the right side also. What are the signs and symptoms? Hoarseness, stridor, cough, air obstruction due to membrane extension, weakness, palpitation due to myocarditis, limb weakness or paralysis due to neuropathy, and in cases of cutaneous diphtheria, punched out ulcer with grayish membrane is present. This is a figure showing the symptoms of diphtheria. It is from the website of Cleveland Clinic. It is showing throat pain, fatigue, mild fever, grayish coating on throat, swollen neck, problems breathing or swallowing. Again, you can see that grayish membrane coating on the right side in the figure. And the clinical features of respiratory diphtheria include sore throat, low-grade fever, grayish-white pseudomembrane over the tonsils, pharynx or larynx, painful swallowing, cervical lymphadenopathy, and bull neck appearance due to severe neck swelling. And the systemic toxin effects may include myocarditis, neuropathy, and renal tubular necrosis. Again, these are the complications which, as I just mentioned, can be myocarditis leading to death, neurological complication like paralysis of palate, oculomotor complication, or peripheral nerves can get involved. Airway can get obstructed. There can be renal failure. Secondary bacterial pneumonia can also occur, and death due to cardiac arrhythmias or respiratory obstruction. So, how can we diagnose diphtheria? It can be clinical due to presence of pseudomembrane, history of incomplete vaccination, signs of airway obstruction. Or it can be laboratory diagnosis based on culture from throat swab on Loeffler's medium, PCR for toxin gene, ELEC test for toxin production, In CBC, we can see mild leukocytosis, and ECG we can do if myocarditis is suspected. So you can see on the right side, Corynebacterium diphtheria is seen growing on blood agar palate, and you can see it in different types. And on the lower pictures, you can see the again the colonies of Corynebacterium on mycloid growth agar or blood agar plate. There's a difference in blood agar plate and the in the color. So, what is the management of diphtheria? It includes diphtheria antitoxin, which neutralizes circulating toxin. It is given immediately without waiting for lab confirmation and dose based on disease severity. And then we have antibiotic, which include erythromycin or penicillin for 14 days, which can eliminate organism carriage. Then we have supportive care in the form of airway management, intubation if needed, bed rest, management of myocarditis and neuropathy. Isolation should be done until two consecutive negative cultures, which should be done 24 hours apart. Now we will see the levels of prevention applied to the diphtheria. So we will be doing primary prevention, secondary prevention, and tertiary prevention. In primary prevention, we have vaccination, which is the most effective measure. Vaccination exists in the form of combination like DPT, DT, TD, DTaP vaccines, and the schedule which is followed is usually 6, 10, and 14 weeks in our EPI schedule, and boosters can be given at 18 months or at 4 to also at 4 to 6 years, and TD boosters every 10 years for adults. High community coverage greater than 90% prevents outbreak. In the coming slide, we will see how much coverage is present in Pakistan and in the neighboring countries. So we will be doing comparison of the coverage of vaccination. So, another important aspect of primary prevention is health education, which is to realize, to make the community educate about the importance of routine vaccination and hygiene, about hygiene and avoiding close contact with symptomatic individuals. Then there are precautions which can be done, like severe allergic reactions to vaccine component if there is any severe allergic reaction. So vaccination should not be given. And if in case of moderate to severe acute illness, the vaccine should be postponed. Secondary prevention. Secondary prevention depends upon early case detection, which can be by sore throat with membrane, bull neck swelling, stridor, or breathing difficulty. Again, it can be done by laboratory confirmation, like I mentioned before, by culture and toxin detection. And then isolation of cases should be done. Droplet precaution should be followed by everybody in order to prevent the spread, and negative cultures are required before ending isolation. Contact tracing should be done to identify close contact like household, school, healthcare exposure. Post exposure prophylaxis include antibiotic plus booster vaccine for all close contacts, and monitor contacts for 7 to 10 days. And in cases of outbreak, control measures should be applied like rapid vaccination drive, screening for carrier, school health alerts, and so on. Now we come to tertiary prevention. Tertiary prevention, the most important is management of complication. Like in cases of myocarditis, ECG monitoring, management of arrhythmias should be done. In case of neuropathies, physiotherapy and airway protection should be done. In cases of airway obstruction, intubation and tracheostomy can be done. Rehabilitation and follow up, monitoring of cardiac function, neurological rehabilitation should be done, and nutritional support to be provided. Then we have public health reintegration, which can be done by counseling families on completing vaccination schedules, strengthening EPI outreach programs. Now we come to the burden of the disease. First, we will cover the global burden of disease. Diphtheria persists in low vaccination areas, significant outbreaks in India, Indonesia, Nigeria, Bangladesh, Yemen. Case fatality rate is 5 to 20% in cases of severe cases. So, according to WHO, disease is resurging due to conflict settings, vaccine hesitancy, and overcrowding in areas like refugee camps. And outbreak patterns are common in children and adolescents, and occasional adult cases due to waning immunity. So, this is the world map showing the share of 1 year old vaccinated against diphtheria, tetanus, and pertussis (DTP) from 1980 to 2024. So, the left side is showing the vaccine coverage in 1980, and the right side is showing the vaccine coverage in 2024. First of all, we will observe the 1980 side. As you can see, there are many lines on most of the countries, which shows that there was no data available from that time, or they did not share that data. And for Pakistan, you can see that Pakistan is in the lightest. Sorry, Pakistan is in the lightest of the yellow region, which shows that Pakistan had only 0 to 20% coverage between that. And similarly was for India, Afghanistan, and Bangladesh. So our neighboring countries had similar, and Africa also had. And now coming to 2024, we can see that Pakistan is in the range of 80 to 90 percent. India has the 90 to 95% coverage, and like China, Russia, we can see they have 100% coverage, and this is Saudi Arabia also having 100% coverage, Egypt also having 100% coverage. So it can be manageable if there are right policies. This is Iran also having 100% coverage. So you can see that these are examples from the countries which are present in Asia and in our neighboring countries. So 100% coverage is should be the goal, and it can be achievable from 95 to 100% coverage. So vaccination coverage against diphtheria, tetanus, and pertussis versus GDP per capita 2024. So this is showing the x-axis is showing the GDP per capita of the countries, $1,000, 2,000, leading up to $100,000, and this is showing the vaccine coverage of DTP, 20%, 40%, 60%, 80%. So, Pakistan has the GDP per capita slightly above $5,000, and we are doing very good for the GDP per capita we have. So we are managing it in low resources, and we have a high percentage according to the available data. India has GDP capita of around 10,000, and it is having slightly better coverage, about 5 to 10%, 5% more than us. So that is to be expected. Similarly, we have the example of Singapore, who has the GDP of about 100,000, and they have the nearly 100% coverage of GDP per capita. So then we have some countries like Azerbaijan who have GDP per capita above 20,000, way more than Pakistan and India, but their vaccine coverage is still around 50%. So it is just not about the money, it also involves the political commitment, the community involvement, and the community education. All these are very important in cases of vaccination program. So it's just not about the resources, as you can see from this. So now we have national burden. Pakistan reports sporadic outbreaks, especially in areas with low DPT coverage due to challenges of weak surveillance, incomplete immunization, and delayed diagnosis. Multiple outbreaks documented in Punjab, KPK, Sindh, and Balochistan. EPI coverage, DPT coverage remains below WHO recommended 90% in many districts. We have around 84% coverage of DPT still, and India is above 90%. So now you can see this is the map of Pakistan with districts of diphtheria cases. Diphtheria case range is this is the data from the 2023 in the cases which were which were diagnosed of diphtheria in 2023. So you can see that 1 to 25, it's the lightish orange color, and it was the cases in most of the country, most part of the country, except in some parts of KPK where there were more cases, and this is unfortunately Karachi, where the cases were even higher. So apart from that, the cases were of relatively lower range, particularly in Punjab. And this is the epidemiological trends of the diphtheria cases and DPT vaccine coverage in Pakistan between 2000 to 2023. Basically, they are showing the cases in the line below, and the DPT coverage is shown in the yellow line above. So this is kind of following the trend of they try to see why there were so many cases above than expected in 2023. The reason which can be seen was the drop in coverage in the 20 and 2021 in due to COVID-19, which resulted in the diphtheria going above the expected numbers in 2023. So this is the so now we come to recent advances. This is an article on 14th July 2025. It is saying that routine immunization protects against this highly contagious disease, but Europe has recorded hundreds of cases between 2022 and 2025. In June 2015, Spanish media began reporting a severe case of diphtheria in a 6 years old boy. The child had not been vaccinated and was in intensive care. Spain, Europe, and the world were shocked. The boy spent 25 days in hospital receiving antibiotic and antitoxins in an attempt to slow the damage to his organs. So this was the Europe is still suffering, and they are trying their best. And this was the political kind of reaction. So the WHO response to this was essential program on immunization for diphtheria began in 1974. Combination diphtheria vaccines were introduced as part of this program since its inception and have prevented greater than 90% of cases of diseases between 1980 to 2000. WHO continues to work with member states to promote vaccination to sustain vaccine coverage and prevent diseases in community. In recent years, there have been outbreaks of diphtheria due to inadequate vaccine coverage. To control these outbreaks, WHO has worked with member states in outbreak response and in strengthening routine immunization program. This is an article about the re-emergence of diphtheria after COVID-19 pandemic in Pakistan. Time to consider booster vaccine strategies. And this is telling is the, this is talking about the same trend of more cases in which were observed in 2023 after the COVID-19, and the reason was maybe hypothesized to be the decrease in vaccine coverage during the COVID-19 time period. Pakistan had sporadic transmission of diphtheria since 2000, and the first outbreak of diphtheria was documented in 2013. Localized diphtheria outbreaks in Pakistan were also documented from 2017 to 2022. After COVID-19 pandemic, the diphtheria outbreak surpassed all previous records. According to Ministry of National Health Services Regulation and Coordination, from January 1 to December 27, 2023, a total of 996 diphtheria cases, uh, 912 suspected and 84 lab confirmed resulted in 124 deaths were recorded from all provinces of Punjab, Pakistan, mostly in Khyber Pakhtunkhwa 58%, Sindh 24%, Punjab 14%, and Balochistan 2%, followed by Islamabad at 0.3, and Azad Jammu and Kashmir. So now we come to the multiple choice questions. Um, So we have MCQ. A 6-year-old child presents with sore throat and a thick gray membrane over the tonsils. Which organism is responsible?
B.
Yes, it is
B.
the thick. Yes, the thick gray membrane is the basically the one. Okay, so the most dangerous complication of diphtheria is A. Pneumonia, B.
B.
Myocarditis, C.
B. Myocarditis.
Yes, myocarditis, because it can lead to straight to death. Yes. In refugee camps, several cases of diphtheria appear within 1 week. Crowding, poor ventilation, and low vaccine coverage are documented. What is the most critical step to prevent further transmission? A. Improving nutritional programs. B. Mass vaccination with TD vaccine. C. Providing insecticide treated nets. D. Constructing new toilets. E. Starting routine hand washing sessions.
B.
Yes, mass vaccination should be done in refugee camps. A laboratory confirms diphtheria in a 9-year-old. Contact tracing finds a younger sibling who is asymptomatic but has a positive culture for Clostridium diphtheria. What is the correct classification for this sibling? A, subclinical case.
Subclinical.
B, latent infection. C, carrier probable case. Yes, it should be subclinical
C.
case because it was in contact with the another child. Yes. A district reports a sudden rise in suspected diphtheria cases, but only 20% are laboratory confirmed. Many samples arrived late or improperly stored. Which public health strategy best improves diagnostic accuracy during an outbreak? Stop laboratory testing and treat all clinically. Strengthen sample transport system and train health workers. Test only severe cases. Replace culture with throat microscopy. Send samples to private laboratories only.
D.
Yes, the focus should be done on sample transport systems. A 6-year-old child with diphtheria dies within 24 hours of hospital admission. Investigation shows he was unvaccinated. What indicator is most important to review for preventing further death? Hospital bed occupancy rate, routine immunization coverage for DPT-3, number of ENT specialists in the district, birth registration system, private sector pharmacy records.
B.
Yes,
B.
yes, routine immunization should be checked. During a school outbreak, the attack rate is found to be highest among children aged 7 to 9 years. Most of these children did not receive a booster after age 5. What is the most appropriate control measure? Provide boosters to children age 7 to 9 only. Conduct a school-wide TDD booster campaign. Close the school for 2 weeks. Give antibiotic to teachers only. Introduce screening at school entry.
B.
E.
Yes. So a school-wide TD booster campaign should be done. A district public health team conducts risk assessment for diphtheria. Which group is at highest risk and should be prioritized for booster vaccination? Young adult in universities, rural farmers, healthcare workers in pediatric wards, office workers in private companies, or children attending private schools.
Children
C.
attending private schools. E.
C.
Basically, I think it should be both healthcare workers in pediatric wards and children attending private schools. So this MCQ is incorrect. Both options are should be okay. A country faces recurrent diphtheria outbreak despite routine vaccination. Surveillance reveals low reporting, poor case definition use, and weak follow-up. Which action will most strengthen diphtheria surveillance? Providing free antibiotic, conducting healthcare worker training on case detection and reporting, increasing hospital beds, providing financial incentives to families, or introducing new laboratory machines.
B.
B.
Yes, it should be B, starting with a case detection. In Hyperton district, you observe many suspected diphtheria cases, but confirmatory test shows that many were tonsillitis. What is the most appropriate public health response? Ignore suspected cases unless where apply stricter laboratory confirmation criteria, update and disseminate standard care of definitions. Um, Update and give and disseminate standard case definition, reduce surveillance to monthly reporting, or restrict diagnosis only to specialist.
B.
C. B. B.
Public. Basically, it should be C, updating and disseminating standard case definitions. So,
Oh yes. C.
yeah,
C.
so it can be that. So this is the YouTube link where the video will be uploaded. And thank you very much for listening.
Thank you so much,
Thank
Dr.
you, Taimia.
Taimia. It was a wonderful presentation.
Thank you. Thank you very much.